Greetings and welcome to our November edition of Disparities Dialogue. I'm delighted to announce that we are discussing Alzheimer's disease and Alzheimer's disease-related dementias this month, and we have a wonderful panel of experts who have kindly taken the time and trouble to join us today and lend their expertise to this discussion. So our panelists, first I'll introduce myself. I'm Bruce Oviagale and I'm a professor of neurology at UCSF. I'll be the moderator today. We have Dr. Bubu, who's an associate professor of neurology, psychiatry, and population health. He's also the director of the Aging Research in Sleep Equity and Dementia program at New York University. We are also fortunate to have Dr. Erin Sundermann, who's associate professor of psychiatry. She's the co-director of the Sustained Training in Aging and HIV Research Program at the University of California, San Diego. And last but certainly not the least is Dr. Zuelsdorff, who is Assistant Professor of Nursing and co-lead of the Community Partnerships Core of the Wisconsin Alzheimer's Disease Research Center. And she's at the University of Wisconsin-Madison. Welcome all of you, and thank you for kindly joining us. So what we'll do as part of this edition is first go through the articles that we have selected to talk about today, and then subsequent to that, we'll then have each of our experts talk a little bit about what the article is about and also help us to contextualize the implications and future research directions for that particular article. So we have 9 articles today. The first article will take a look at the economic burden of Alzheimer's disease and related dementias by race and ethnicity 2020 to 2060. The next article will take a look at regional differences in dementia incidence amongst US veterans. Our third article will take a look at the incidence and prevalence of dementia among US Medicare beneficiaries from 2015 to 2021 and is a population-based study. Our fourth article will take a look at sex differences in mortality and healthcare utilization after a dementia diagnosis. Our fifth article examines neuroimaging markers of dementia across race, ethnicity, and sex gender using an intersectional approach within the HABS-HD cohort. Our sixth article maps the disparities in access to lecanemab in Georgia. This article takes a look at the introduction of the social determinants of health into the Alzheimer's Disease Research Center network and speaks to the development and implementation in the uniform data set. We also have an article looking at enhancing participation of historically minoritized groups in Alzheimer's disease and related dementias research. And this is derived from a national conference report. And then finally, we have an article that takes a look at bridging gaps in dementia care across Southeastern Europe, regional challenges, cross-border innovation, and implementation barriers. And so now we'll move to our elaborations on those articles. And we'll start off with the very first article. This article is published in JAMA Netw Open, and it speaks to the issue of the economic burden of Alzheimer's disease and related dementias by race and ethnicity 2020 to 2060. And Dr. Michael Bubu is kindly going to walk us through this particular article. So Michael, what were your thoughts about the overall article in terms of what they did and what they found?
Yes, I mean, the background just relied on the fact that Alzheimer's disease-related dementia, that they impose large and growing costs in society, and that there are racial ethnic disparities in these burdens, and that these have not necessarily been well characterized. So what they did basically was use a nationally representative data. This included the Medical Expenditure Panel Survey, the National Study of Caregiving, and then the 2013 Panel Study of Income Dynamics, and applied, setting kind of modeling to basically estimate project ADRD, meaning Alzheimer's disease and related dementia-related economic burden from 2020 to 2060 and looked at it by race and ethnicity strata. So their findings basically, show that African Americans and Latino adults bore slightly higher than a third, of the total ADRD burden, and that by 2060, their combined burden was projected to reach about 1.7 trillion. So basically surpassing the projections for white adults. The studies, I think it did have limitations, and some of the things was relying on assumptions about future disease prevalence, costs or demographic trends and caregiving patterns, and that, these may not necessarily capture the study, itself may not necessarily have captured or measured costs or changes in health policy or medical advances because it relied on, the now and used that data for projection.
Right.
So I think in summary, really, we do see that certain minoritized communities with ADRD and their caregivers are likely to face disproportionately high and accelerating economic burden relative to white older adults. And I thought the implications really was for policy and policymakers and health systems, the need to prioritize targeted resources, interventions, and support policies to mitigate these escalating financial strain that possibly would hit racial ethnic minority communities that are affected by Alzheimer's disease and related dementia.
No, thank you so much, Michael. And I know that you had a table here you just wanted to highlight that came from the article. Do you just want to speak to this briefly?
Yeah, so I mean, this table just basically showed the actual 2020 and then the projected 2030. Then you have 2040, 2050, 2060 amounts, which these are costs that are based on population numbers from the Census Bureau. And the assumptions, like I said, assumed 10 hours of weekly care for those reporting receiving less than 20 hours of care, which was slightly over half of the population, and 30 hours of care for those reporting receiving greater than 20 hours of care, which is about 42%. Generally, what you do see is based on, you do see that initially, or generally, because of the population in terms of numbers, sheer numbers, you do see that the numbers are higher for whites. But then over time, right, with respect to the increase within race strata, if you combine the increase in terms of economic burden, you will see that the African Americans and Latino populations, their total cost was 113 billion in 2020, and the projected increase was to 1.7 trillion in 2060. And so that basically surpassed the economic burden for white population that increased from 231 billion to 1.4 trillion.
That's very helpful. And two questions, if I may, Michael. Number one is, of course, cost can have several components. Which components of cost most contribute to the disproportionate burden on Black and Latino communities? And secondly, it's always wonderful when we identify these issues and challenges, but what policy or health system interventions could potentially help to reduce this future impact, economic impact on caregiving strain on minoritized populations?
Yeah, so I think this is in terms of like the cost drivers, in terms of the economic burden, it's within racial ethnic groups, the prevalence and the burden of the disease being more, in certain groups, or necessitating a lot of caregiver support. Those things add to the cost, and then they drive, the cost with respect to the racial ethnic minorities there. I mean, policies just need to follow the data and look at the fact that, you have a higher burden in certain racial ethnic groups. You have social structural determinants of health that are impacting these groups more in terms of, you have more in terms of caregivers, you have more in terms of the burden of the disease, you have more in terms of less education, access to healthcare, and all of those other things. So I think, understanding the economic burden of ADHD as a whole across all racial ethnic groups, right, is important. But then it is important to begin to target policies that would help mitigate, situations, especially for racial ethnic minoritized individuals, things that would definitely result in loss of wealth, lower retirement savings, increased borrowing and debt and all of that stuff, and increased reliance on government-funded income and health insurance programs. These are things that will be impacted. So policies have to focus on those potential factors to mitigate anything that would, result to adverse effects or outcomes really on these racial ethnic minoritized individuals.
That's terrific and well said. Thank you, Michael. We'll now move to the second paper, and this one actually addresses population I'm very familiar with. I work within the VA and looks at the issue of regional differences in dementia incidence among US veterans, and was published in JAMA Neurology earlier this year. Michael, kindly take us through this.
Yes, so prior US studies have not necessarily fully characterized geographic variations in dementia incidence across regions using a large national veterans cohort, and that's what this study tried to do. So the authors assigned participants, veterans ages greater than 65 years, to 10 US regions based on zip codes, and used a regression analysis that we call Poisson regression. They adjusted for demographics, comorbidities, and they estimated region-specific dementia incidence rates and ratios within this Veteran Health Administration data set. So what they found was dementia incidence varied widely by region, and you could see that with the Mid-Atlantic showing the lowest rate, and then the Southeast had the highest rate, and this is after adjustment. And several regions exhibited, between 12 to 25% higher risk relative to the Mid-Atlantic region. Now, the significant limitation really of the analysis is the use of administrative ICD codes for dementia diagnosis, which can possibly lead to misclassification of cases. And of course, the elephant in the room is that the veteran population is predominantly male.
Right.
And so this limits generalizability generally. So generally, in conclusion, we see significant regional differences in dementia incidence, and that this persists even after covariate adjustments. So basically suggesting spatial heterogeneity in risk factors or possible diagnostic, practices in terms of differences across the US veteran population. I think the implications really tie to the fact that it's important to understand these geographic variations and using information from that to guide regional targeting of dementia prevention, surveillance, and health policy interventions within the veteran health systems.
Thank you, Michael. And I know you had a graphic here you wanted to just highlight for the viewers.
Yeah, so the graphics just basically show what we just talked about, that you had, the highest incidence in the Southeast region, in the Northeast and Rocky Mountains, and the lowest in the Mid-Atlantic regions. There were regional differences, as you can see, across all regions, basically, after adjusting, the adjusted incidence rate per 1,000 person years or the rate ratio.
And so, of course, the question is why, Michael? So to your mind, what regional factors might explain these regional incidence differences?
Yeah, I think there are multiple factors that play a role. One of the things that the paper did show was um, the regions that had the higher incidence, you could actually look at they had lower level of education that could possibly drive those findings. Other issues which may not really apply here are like access to health care. This is the Veterans Health system, so that may not necessarily be an issue. However, though, health-seeking behaviors can impact this. The question of rurality comes in because many of the rural regions as well, which have limited access to resources, that plays a role as well. And then, of course, social structural determinants of health, how they vary across these regions, also help drive some of these findings that we see.
Oh, thank you. Thank you for that. We'll now move to our third article, and this was an article published in the British Medical Journal, BMJ, and took a look at incidence and prevalence of dementia among US Medicare beneficiaries over a 6-year period. Michael, you want to talk about this one, please?
Yes. So the authors noted a lack of recent large-scale estimates of dementia incidence and prevalence in Medicare beneficiaries, and decided to look at this and stratified by demographics and socioeconomic factors. So they used a fee-for-service Medicare claims database, 2015 through 2021, in beneficiaries aged greater or equals to 66 years. The authors, they identified both incident and prevalent dementia cases using validated ICD algorithms. They also looked at age and sex standardized incidence and prevalence rates across various subgroups. The finding in summary was that age and sex standardized incidence declined from about 3.5 to 2.8. That's from 2015 to 2021. But the prevalence increased. It increased from 10.5 to about 11.8. And there was persistent disparities by sex, race, ethnicity, and area deprivation. Now, the limitation really of the study is the reliance on administrative claims data that may underestimate dementia cases, misclassify diagnosis potentially, and the lack of generalizability to Medicare Advantage enrollees or uninsured populations. I think in summary, what the paper really showed is dementia incidence appears to be decreasing in this Medicare cohort, even as prevalence continues to increase. And you see disparities in burden remain across demographic and socioeconomic strata. I think the implication really is the trends, especially the increasing prevalence trends, they underscore the need for improved dementia detection, equity in care, because we're seeing racial, ethnic, minoritized group impacted disproportionately, and then policy planning that are tailored to these high burden subgroups identified by demographic or socioeconomic factors.
Great, thank you. And you had a graphic here. You just wanted to bring it all home to the viewers?
Yes, as we can see, the darker shades represent where you have, whether it's higher incidence or prevalence, and you can see pretty much mirroring the previous study that we discussed with most of the concentration in the southeast, regions. But incident dementia rates, as we said in 2015 and 2021 by U.S. county, overall the incidence generally concentrated in what we will call the stroke belt, so the regions of the southern U.S. And then the prevalent rates by county is shown on the right, and the trend is similar to that seen for dementia incidence. It's just that you have an increase in prevalence overall.
No, thanks, Michael. It's quite fascinating. You stole my thunder there, that this just seems to overlap very well with what we know as the stroke belt. These states, mostly in the southeast, that have a higher incidence and mortality from stroke than the rest of the country. And this aligns so well. So it's interesting to see how these seemingly different disease entities but related inform each other when it comes to this distribution pattern. The question I had for you, Michael, in regard to this particular paper and its implications are: how do changing diagnostic patterns, healthcare utilization, or population demographics help explain these observed trends?
Yeah, I mean, I think it ties again to what we discussed previously, right? The lack of resources, lack of training, um, in terms of diagnosis and all of that where there are variations in the diagnosis and patterns, then you can definitely have some of these differences. Socioeconomic stresses and factors also play a significant role in driving these differences that we see. I think that the reduction in the incidence that we're seeing, um, reflect, care in terms of um, improvement in cardiovascular care, basically. I think that's my thought process, uh, because cardiovascular disease is a big risk factor for dementia and its incidence. So I think with improved care, generally overall, you see that. But then with specific certain subgroup populations where social structural factors can drive, access to care, quality of care, diagnostic differences patterns that we may see that varies across different regions, or even educational level. And then, many of these regions, you can see these are places where people will move to when they retire.
Right.
So you have those distributions, age distributions different from other parts of the United States generally. Rurality may play a role as well, and so, but you're seeing the impact in certain subgroups, right, across racial, ethnic, minoritized people.
Right. Thank you, Michael. We're going to switch to Erin, and we're going to start off with this article that was published in JAMA Neurology, speaking to the issue of sex differences in mortality and healthcare utilization after dementia diagnosis. Erin, could you kindly walk us through this one?
Yes, happy to. This study was born out of the idea that there's sex differences in dementia incidence and outcomes, but it's unclear whether women's higher dementia mortality reflects higher mortality after diagnosis or is simply an artifact of the fact that women have higher rates of dementia. So what they did is they used nationwide Medicare data from 5.7 million adults age 65 and older with incident dementia from 2014 to 2021. They compared mortality and healthcare utilization by sex after adjustment for demographics, comorbidities, and county level healthcare resources. So their main findings were that it was the male patients that consistently showed a higher adjusted hazard of mortality, hospitalization, hospice use, need for neuroimaging, and dementia-related admissions compared with female patients. And they looked at this across 1, 3, and 5-year follow-up periods, and it was consistent for these follow-up periods. Limitations of this study are, of course, this was claims-based dementia data, which has its limitations. There was a reliance on binary sex from Social Security records. They did not examine dementia subtypes. And of course, Alzheimer's disease is known to have a large sex difference, and restriction to fee-for-service Medicare users. So in conclusion, these findings suggest that men experience higher mortality and greater use of different healthcare services after dementia diagnosis, and suggests that women's higher dementia mortality is driven more by the fact that they are at higher risk rather than their poor survival after diagnosis. So implications from these findings are that reducing dementia burden will require prevention efforts tailored towards women, while targeted strategies to reduce excess mortality and acute care use among men may improve equity in dementia care.
No, thank you for that, Erin. And of course, this great study begs a lot of questions. One question I did want to ask you is, since women are more likely to develop dementia but tend to live longer after the diagnosis, how should we rethink prevention and care strategies to address those different needs and reduce the sex-related gaps in dementia burden?
Yeah, so yes, the article suggests that women's higher population dementia mortality is driven by their higher incidence, not so much worse outcomes after diagnosis. So this pattern implies that prevention strategies really should be more intensely directed towards women. They should be directed to both sexes, of course, but women particularly addressing modifiable midlife risk factors that seem to disproportionately affect women, like cardiometabolic conditions and menopause-related changes. On the flip side, care strategies for men need to account for their higher post-diagnosis mortality and greater healthcare utilization by strengthening early detection, better care coordination and caregiver support for males with dementia. So in short, if we're with a lens towards equity and dementia outcomes and dementia care, approaches should really pair prevention targeted particularly to women with post-diagnosis risk mitigation targeted to men, kind of recognizing that sex differences in incidence and survival call for different interventions along the trajectory.
Right. Absolutely. Thank you for that. The next article was published in the journal Alzheimer's and Dementia and took a look at neuroimaging markers of dementia across race/ethnicity and sex/gender using an intersectional approach within a given cohort. Erin, could you please walk us with this one?
Yes, so I really like this article. This is very rarely examined, this intersection of race and ethnicity and sex and gender, despite the fact that race, ethnicity, and sex gender show differing risk and pathophysiological profiles of Alzheimer's disease and related dementias. So what they did was they used cross-sectional baseline data from 3,433 dementia-free adults in the HABS HD cohort. This is the health and aging I'm blanking on the B study, health disparities, brain study, maybe health disparities cohort. The authors analyzed PET and MRI markers of neurodegeneration and small vessel disease by modeling both interaction and effect modification between race, ethnicity, and sex gender. Their main findings were that Black participants, especially Black men, had lower amyloid burden, while Hispanic and Black women had higher medial temporal lobe tau deposition. And Black participants of both genders had greater small vessel disease compared to non-Hispanic white participants. Limitations or generalizability. This is a study that takes place in Texas, so it's a single site recruitment. Of course, there's sample imbalances and the numbers of the different cells of sex, gender by race, ethnicity, and of course, the binary categorization of sex and gender. Major conclusions are that these neuroimaging AD markers differ jointly by race, ethnicity, and sex gender, with patterns suggesting that effect modification rather than interaction is occurring. And so this highlights distinct pathways through which social and biological factors may intersect to influence dementia-related pathology. Implications from these findings are that intersectional biomarker research better informs precision medicine and public health strategies by identifying population-specific targets for prevention and intervention, particularly for communities disproportionately burdened by dementia.
Yeah, no, thank you, Erin. I also found this an elegant and highly informative study. I had two questions for you, if I may, please. One is, given that Hispanic and Black women showed the highest medial temporal lobe tau deposition, how might structural discrimination and biological sex-related factors interact to shape these disparities, and what additional data would we need to help disentangle these pathways?
Yeah, so the elevated medial temporal lobe tau deposition observed among Hispanic and Black women likely reflects an intersection of structural racism and structural sexism, along with biological sex-related vulnerability. So chronic exposure to racism, gendered caregiving burdens, economic disadvantage, and reduced access to good quality preventative care may interact with biological processes. For women, this could be menopause-related hormonal changes. There's major sex differences in the immune response and inflammation, which of course we know is very important in Alzheimer's disease pathology. And in stress physiology, which shows sex differences. All these things could come together to kind of amplify tau accumulation in these groups. So the article suggests that these women may face dual vulnerabilities rooted in both social and biological mechanisms, and data that could help to disentangle this. If I was to design the perfect study, I would want, a lot more social disparities of health data, things about lifetime exposure to racism, caregiving burden, questionnaires about, menopause characteristics, inflammatory markers. There's so much that could be added to this to kind of help disentangle these things.
Thank you so much for that, Erin. We'll move to the next paper, which is an important one as well. It's a short report, but nonetheless speaks to a crucial issue, especially during these times, and that's access to key medications. And so this is published in Alzheimer's and Dementia, and takes a look at mapping disparities to access in lecanemab in the state of Georgia. So, Erin, your thoughts about this one?
Yeah, I thought this was a really elegant article that really with some major implications, given that these amyloid fighting drugs are on the rise. So lecanemab, it offers a new disease modifying treatment for early Alzheimer's disease, but the access may be limited by geographic disparities in the availability of amyloid PET scan, which you often need to have to show that you have the amyloid, which is the indication for being prescribed this drug, and the infusion facility. So this drug is actually injected, so you have to go to an infusion facility. The study mapped all amyloid PET scan and lecanemab infusion sites in Georgia, and they used Google Maps based drive time analysis to quantify county level access by rurality and health professional shortage designation. They found that there was no rural counties that had amyloid PET facilities, and only one had a lecanemab infusion site. So this results in a significantly longer drive times for rural versus non-rural residents. And they calculated 1 hour to 1.5 hours for rural residents. Limitations of the study is that, these findings rely on potentially incomplete facility lists and estimated rather than actual travel patterns. This was limited to within the state of Georgia, so out-of-state travel was not accounted for, and of course this was limited to Georgia, so we don't know how this would generalize beyond. Major conclusion is that geographic inequities in access to amyloid PET scans and lecanemab infusion centers disproportionately affect rural counties, underscoring substantial health equity challenges. And the implications are that policies and systems level interventions such as transportation support, telehealth programs, and portable or more widely distributed scanning and infusion capabilities are needed to improve equitable access to Alzheimer's disease treatments.
No, thank you for that, Erin. And it's interesting, of course, in Michael's the papers that he discussed, of course, we were reminded about the regional and rural burden of Alzheimer's disease. To your mind, given that rural counties show both a higher burden of Alzheimer's disease and also have these longer drive times, what policy or health system strategies, and you've mentioned a few of those in your, as you mentioned, the implications, might be the most realistic and the most impactful in closing these gaps?
Yeah, it's a good question. They talked a little bit about this in the discussion. Realistic strategies to help close these gaps include mobile or portable PET imaging units, which the authors explicitly list as a future direction. Subsidized transportation programs that could support both patients and caregivers. And a big thing is just expanding provider training, so more rural clinicians can diagnose dementia, can interpret amyloid PETs, and administer lecanemab. It's possible that increased telehealth consultation capacity could also reduce number of in-person specialty visits. Of course, that can't take the place of PET imaging or infusions, but it could at least help decrease the burden of the number of in-person visits required. And I think a lot of this points to just the severe rural workforce shortage described in the paper, which is a major barrier. And a combination of these mobile diagnostics, transportation support, and expanded rural clinical capacity could likely yield meaningful improvements.
Yep, agree. Thank you so much, Erin. We'll now move to our 7th article, which Megan will kindly discuss. And this is an article published in Alzheimer's and Dementia and takes a look at introducing social determinants of health to the Alzheimer's Disease Research Center network, the development and implementation of uniform data sets. And Megan's discussing this. She pioneered this particular paper, so extremely grateful to her to have her to contextualize the work that they did here.
Sure, thank you, and I'm happy to do that. This was sort of a multi-year effort, culminating in the addition of a social determinants of health module to the new UDS version 4, which is just currently replacing version 3 across all of our ADRCs, of course. And the driving background or significance of the whole initiative was really that though our national ADRC network, which includes, over time, tens of thousands of participants, although as a network, we've always collected incredibly rich clinical and cognitive data via that harmonized uniform data set, we also have historically lacked any kind of standardized collection of social determinants of health measures. And this is a significant barrier to understanding population level disparities in ADRD related outcomes, not just ADRD risk, but also recruitment and retention into our ADRCs, modifiability of ADRD risk factors, as well as participation in intervention studies that we may want to direct people toward. So basically, the clinical task force did sort of commission this transdisciplinary committee of scholars who do work in ADRD and particularly in social and structural determinants of ADRD to develop a data module that could be included. And we had a couple very limited sort of parameters going in. We knew that this had to be brief, so probably not more than about 20 minutes to complete. And it should sort of cover several constructs so that we were measuring more than one thing. And that was actually a bigger challenge than you might expect. So there was sort of a process where we had to select criteria on which we would make the rest of the selection as a committee. And then we had to actually select the constructs themselves according to those criteria, as well as the measures that would be used to operationalize each construct. The criteria that we sort of settled on as a committee included constructs and variables that we knew had strong or plausible causal links to ADRD. It says Alzheimer here, but it was ADRD related outcomes. Again, not just including risk, but also including determinants of modifiable ADRD risk factors, and as well as participation in ADRC related studies. They also needed to be relevant and variable, show variation already across the existing NAT cohort. So we know that a lot of ADRCs are currently involved in outreach and engagement of communities and populations that have been underrepresented. But we needed it to be applicable to the existing NAT cohort rather than sort of the NAT cohort that we'd like to see in terms of representation in the future. We also prioritized constructs that could be either drawn from validated instrumentation or harmonizable with other large and sort of sustained aging cohort studies. So, for instance, the health and retirement study. We thought that for a given construct, if we knew that it had been measured a particular way in a very large and ideally population-based and nationally representative aging study, we could do more to contextualize the findings. And finally, because we know that there's been a big push recently to use geocoded data and linkage through, say, public data sets that are available, we specifically prioritized for items that would be self-reported by participants, those constructs that were not really measurable through, say, geospatial data linkage. So we wanted things that would be complementary or in addition to what you could normally get from linkage. Ultimately, the final data module collects data on transportation and transportation security versus insecurity, financial security, social connectedness, healthcare experiences, and discrimination measured quite broadly. The module is required for all ADRC participants at least one visit, and then centers can individually opt to collect data across repeated visits or follow-up visits. In terms of key limitations that I think a lot of us felt very deeply, this module obviously is not exhaustive, right? We could not cover all of the important constructs that a lot of us felt needed to be covered. It was quite difficult to narrow down the constructs that we would include. It also is too brief, obviously, to incorporate any full validated instruments. So, how good is validation when you pull 5 out of 10 questions and include them? But at the same time, if we wanted multiple constructs and to stay in 20 minutes, we had to only select, some items. Also, we understand that it's most likely that data in many cases are going to be captured at a single visit only, which is going to substantially limit any insight we have into changes over time, time varying exposures, which obviously most of these are, particularly for aging populations and people moving through later life. That said, despite these limitations, we do feel strongly, and I think that the CTF as a whole does, NAC does, that the addition of the social determinants of health module does address a really substantive gap that was sort of inhibiting a lot of understanding and redress of population level inequities, again, modifiability of brain healthy behaviors, and also participation in research.
No, absolutely. And congratulations, Megan, on this. I think this is fantastic work addressing a very, very important issue. And one can tell from your passion how strongly you feel about it. It's really comprehensive. I think the one question I have here, you kind of alluded to it already, the model couldn't be exhaustive, but what additional criteria or principles could have guided the selection of the social determinants of health variables for inclusion in the UDS?
Yeah, I mean, I think that, full disclosure, so I got to co-chair this committee. So I feel pretty positively about the criteria that we settled on, but I'm always interested to hear from others. So that question, I think, is really important to ask people who didn't get to be involved in the process. Particularly, we tried to have, all of our authors came from ADRCs across the country. I think the biggest struggle we had is that, for when you're representing a given center, you're really invested in serving the communities that surround you. And it's hard to see those communities' concerns and issues that are facing them not addressed in a given module. So we have centers that they serve communities who have a lot of housing insecurity, and certainly that was something that came up again and again. I think that caregiving, in terms of both its burdens and its rewards, would have probably been a great thing to have in here, just because we know that the same populations facing disproportionate dementia risk are also more likely to be providing informal care for, not just people living with dementia, but also the communities around them more broadly. So I think that having factors like that in here would have been key. I think it's also, it's as someone who studies social and structural determinants of health, it's notable that a lot of the factors that we included are relatively proximal rather than sort of traditional social determinants. So we don't have information, say, on insurance coverage or quality. We do ask people, however, about their when I say healthcare experiences, there are items there about their ability to, say, successfully adhere to a prescription or a medication regimen, their experiences with the healthcare quality. It's all self-perceived, but at the same time, hopefully it's complementary to, again, sort of area level hospital quality data that we could ostensibly get by geocoded data linkage.
Good. It's great. Great. We'll move on to the next article, published again in Alzheimer's and Dementia, and this looks at enhancing participation of historically minoritized groups in Alzheimer's disease and related dementias research. It's a national conference report of which Megan again was a part. And so, Megan, your thoughts about this report?
Sure. So very much linked to the article and the problem that we just discussed. This report really comes out of a conference that is part of an ongoing conference series hosted by Washington University in St. Louis that it's being held in recognition of this really pervasive and persistent underrepresentation of many, if not most, historically minoritized groups in Alzheimer's disease and related dementia research. So WashU has now held several conferences that basically bring representatives from all of the ADRCs together to hear about latest initiatives in sort of conducting inclusive science, and then to discuss amongst themselves and basically strategize ways to move forward as a center network. The conference, as I just said, included representatives from not only all, at the time it was 37 ADRCs across the country, but also a number of national organizations, community advocates, including community health center representatives, and presenters were, again, drawn from the ADRCs and were just selected for their expertise and their leaderships in specifically ADRC-sponsored efforts to partner with local communities. So ultimately, we had people speaking directly to community-specific tailored outreach programs for Black and African American communities, Latino and Hispanic communities, Asian American communities and Asian immigrant communities, American Indian and Alaska Native, and also LGBTQ plus. And again, really structured toward thinking about inclusion broadly, all the way from participation to protocol design to dissemination and benefits of the science. In terms of, I think, sort of how it could all be summed up, while ADRCs are increasingly recognizing the importance of including historically minoritized and underrepresented populations, there are still a lot of significant barriers. These include sort of population and historic barriers, such as mistrust that is deeply rooted in past research abuses and institutional abuses, but also a lot of logistical challenges, including sort of under-resourcing of recruitment efforts and a lack of culturally competent staff. To address gaps like these, the participants, as well as the representatives who were there, were proposing strategies that really broadly covered things like sustained community level engagement and partnership, for instance, with community advisory boards, making sure that they were utilizing culturally tailored materials, a lot of flexibility in study procedures, a lot of adaptation in protocol, as well as just the system level investments that are needed to produce all of that and keep it going. I think in terms of implications, what came out of it was just that building trust does require a sustained presence in the community. You've got to actually be there and sort of put in the time. Partnering with organizations is crucial to sort of building that slow process of trust with communities. Transparency and honesty also really key there. And finally, that reciprocity, this actual sort of real partnership, as well as givebacks that are not directly tied to recruitment, are really essential in order to maintain partnerships.
That's fantastic, Megan. I think I just have one quick question, and that's just about the issue of to what extent do the current AD/ADRD research structures limit representation and even reproduce inequities in benefits from science?
Yeah, I think a lot of it comes from when we have limited resources and they don't take us the extra mile. So we can almost, I think it's really tempting, and sometimes it's only possible to do the bare minimum. But then we're all to keep that funding going, right? There's a lot of incentive to talk about what you're doing and make it sound great. And I think that perpetuates kind of a sense that doing less than is truly required is enough. And so what I think you see, and then also understanding is limited, actual community benefits become limited because it becomes a center looking at itself and carrying out these activities rather than sort of hearing, what are we doing right? What are we doing wrong? What do you need? And how do we kind of go beyond what we're currently doing to bring you what you need? And that's when I think you see, we're patting ourselves on the back while we're really doing not a lot to move the needle in terms of where the science is and what the science means to the communities that we should be serving. Sorry, long-winded, but I think
No.
that's how we perpetuate it. I think that we also, we do a disservice when we talk about community and inequities without contextualizing them,
Right.
And including community partners who can really actually help us interpret a lot of findings. Again, we're speaking to each other, but that means that we are perpetuating misunderstandings that we have carried into our own training and, bringing them to future generations of researchers. So I think this is how inequities become really embedded and difficult to change and sort of persist across time, even with people having good intentions.
So well said. So well said. Our last article was published in the Journal of Public Health Research and speaks to the gaps in dementia care across Southeastern Europe. And we're happy, SEQUINS is a global organization. We're happy to have this article that focuses on another continent in essence, but in this case looks at the regional challenges, the cross-border innovation and implementation barriers. Megan, your thoughts?
Yeah, so this was I really enjoyed reading this article. I felt like for me it didn't leave me feeling really hopeful, but I really appreciated the frank discussions that it brought to the forefront in terms of being sort of a call to action as well as sort of a description of what has been done and where is to go. So yes, it was an article specifically about Southeastern Europe, but I think that any of us who are thinking about rural urban disparities will recognize it regardless of where we're coming from, because I think that there's this confluence of in rural areas population level aging, as well as these sort of workforce shortages and disparities in, therefore, caregiving resources that are both related to formal care from the workforce end of things, but also actually informal care as younger populations have to move into urban areas to basically make a living and so on. It becomes difficult to provide that informal care as well. And so as a result, this article pointed out in Southeastern Europe specifically, dementia burden is outgrowing available infrastructure, societal infrastructure for it. To this end, a very solution-focused group convened a multinational consortium of mainly clinicians and healthcare providers from Southeast Europe who basically implemented a survey to assess challenges that their colleagues were facing across nations, challenges in dementia care, and they used the results of this survey to design a number of sort of regional initiatives and projects aimed at addressing those challenges. This was a report rather than sort of an evaluative study, but several initiatives were described. A lot of them covered I would say broadly training initiatives for a workforce. So there was a collaborative network of 12 healthcare and ADRD organizations that were specifically worked to improve professional skills and develop care frameworks for healthcare institutions to use. There was a web-based platform developed to basically expand the reach of all of these resources. And there was a range of overall basic education materials and programming developed for a really diverse set of care providers who might be working to address needs. I thought it was really interesting. They did bring in one more project, which is, was a nice complement to this in terms of the description, that was a network of mobile memory health teams who really did attempt to provide comprehensive ADRD support in rural areas. And I think this is where you really saw the contrast in sort of, what are we pretty well suited to address, and where do we need to do a lot more thinking? In terms of not a limitation of the article, obviously, but a limitation that the team described was that there were major structural challenges they ran into while implementing programs. And that was particularly around actually providing care within these rural communities. Again, due a lot to staffing and other resource shortages that were not addressed through even sort of this grassroots approach of mobile health teams. They identified certainly a need to focus, therefore, on hybrid care models that incorporated innovations like telehealth and similar. I think, though, obviously, when it came down to it, there was an acknowledgement that that kind of delivery is going to be really have to be reimagined in order to successfully address sort of this dual challenge of demographic shifts, which again, we recognize from, it's a global issue at times, but also increasingly limited care resources. And also in terms of equity, when we are talking about these digital solutions, we're going to have to pair them very carefully with community-based adaptations and needs. We know that right now, telehealth seems like a great option. It's probably implemented in a status quo way. It's probably going to widen urban-rural disparities rather than solving the problem.
Yeah, no, absolutely. And you kind of spoke to this issue when you discussed the other paper as well. But if I may, just to reinforce the notion here and connect the two, in what ways, Megan, might cultural perceptions of aging, of cognitive decline, of caregiving influence affect the adoption of innovative dementia care models?
Yeah, I think this is where those community partnerships really come into play. And we have to acknowledge that it is important for some solutions, policy level solutions, to be generalizable based on generalizable data. But there's also a huge role that community specific solutions and data can play, where some solutions may be local. And I think to figure out what those are, this is where community members can really provide a lot of expertise on what their biggest barriers are and what the solutions might be. So, if you have a community that takes significant reward from informal caregiving, that really values it. Now I'm speaking from a US perspective, but they may not be interested in respite care as a solution to eliminate burden, right? Rather, you may want to, that may be a community where financial compensation or assistance with caregiving may be a much more needed and desired solution, whereas another community may be desperate for respite care. That may be what they really need. And I think that there are these huge kind of cultural differences that really need to be acknowledged in terms of uptake and utility.
Absolutely.
And I think we get that from community experts. It's hard to bird's eye view it.
Absolutely. No, I agree. Couldn't agree more. Thank you so much, Megan, for that. I just want to say a big thank you to our expert panelists today, Dr. Bubu, Dr. Sundermann, Dr. Zuelsdorff. Really appreciate you taking the time and trouble to teach us here and to contextualize the findings of many of these crucial studies that have been published in this space over the last year. I certainly gained a lot, and I'm grateful to all of you for that. And then finally, to our viewers and who might be members of SEQUINS or stakeholders in the mission to advance brain health equity through science, we want to remind you that we have an organization, SEQUINS. We have a scientific journal, we have a podcast, and we invite more and more stakeholders to join us in this battle to address the issue of brain health equity and overcome it for all populations who are disparate in nature. Thank you again, and we look forward to another edition of this particular program. In December, we have the program will focus on Parkinson's disease, so look forward to that. Thank you all so much.